Hello, good afternoon. Thank you. Maybe I would like that after my review.
Okay.
I'll very much, yes. If you can save it, yes. If it will last until the review. Thank you. Okay, so shall we quickly do a run through the bacteria? So when you're going through the bacteria, a few points to keep in mind, like how are the questions going to be framed, what are we going to test you? Now, classically, the emphasis would be, of course, on, first of all, you're given a classical scenario, like say, for example, if you're taking Staphylococcus, pardon me, can't hear, I think there's something, okay, so say, for example, you have a toxic shock syndrome, which is a typical infection caused by Staphylococcus. So you could be given, as students, you are definitely expected to know how to recognize a case of toxic shock syndrome. A woman or a male presenting with sunburn-like rash, peeling skin, palm and soles. At least these clues would definitely be there. Then the question could ask about what is the most important virulence factor that is responsible for this, syndrome, toxic shock syndrome. So you need to know it's a toxin, and then the toxin is a super antigen. Okay. Now, or it could be what is the morphological feature of this causative agent. So you recognize it as a case of toxic shock syndrome, you know it is caused by Staphylococcus, and then the question could ask what is another important virulence factor of this bacteria? That's probably coagulase. Or you could be given a case of a skin infection with a picture, a gram stain picture, and asked to identify what is the causative agent. It could be a cocaine clusters, it could be cocaine chains. Okay, so knowing the important characteristic of every bacteria is very, very important, because that is going to be the buzzword. The gram-positive cocaine clusters, gram-positive cocci, that is catalase negative, you can immediately pick out the correct appropriate choice. Okay, now again, you could be given a few clinical symptoms and signs, but if there is a description of the microbe, please ignore everything else. That's the most definitive clue. When it says catalase negative, gram-positive cocaine chains, it is Streptococcus. It cannot be anything else. There is no need to get confused about, oh, but Streptococcus does not cause this. No, nothing. If it describes the microbe, that is the most definitive clue. And that is a buzzword that you need to look for. Okay? So, classical symptoms, what is the most likely causative agent? Symptoms, description of the microbe, then expect the option to be a virulence factor. You see, when we give you a few clues like, okay, this is the microbe that is causing this infection, then you are expected to know what could be the virulence factor that is responsible for this infection. Okay, it could be a watery diarrhea. A case of watery diarrhea, so you immediately know, okay, watery diarrhea could be E. coli, ETEC, or Vibrio cholera. So the question probably could be, what is the mechanism of action of the toxin that is responsible for this condition? Okay, so this is more or less how you're going to see the questions. Okay, so now let's look at a few of the microbes and see what you need to focus on. Okay, so we'll start off with a gram-positive cocci. So you have cocci in clusters. You have cocci in clusters. Okay, cocci in clusters, you know, is staph. Then staph is catalase positive. This is something you are not going to forget. Now we are looking at Staph aureus. Other characteristic of Staph aureus is beta hemolysis. These are all the characteristics. It shows beta hemolysis on blood agar. Now, what are the important virulence factors produced by Staphylococcus? You have coagulase, then you have protein A, then toxic shock syndrome toxin, exfoliative toxin, isn't it? Anything else? Huh? Enterotoxin, good. Enterotoxin. So now with these virulence factors, TSST you would associate it with toxic shock syndrome toxin. So as I told you, sunburn rash, sunburn, there's a rash, peeling skin, and hypotension, shock. Okay. So if you're given this scenario, you should be immediately able to say, oh, this is probably due to toxic shock syndrome toxin, and then they could probably ask you, what is this toxin also? What's the action of this toxin? It's also a super antigen, yes. Okay. So this is probably one way of asking, or they could ask, the causative agent of this disease produces which other virulence factor? Okay. So it could be any of these, okay. Now exfoliative toxin, you could have a baby with peeling skin, okay. And how do you think a newborn will get this staphylococcus from where? From the mother. What's the infection that the mother could probably have that would have transmitted to the baby, a newborn? What's the mother and baby newborn? Breastfeeding, isn't it? So what infection caused by staphylococcus in a breastfeeding mother can be transmitted to the baby? A breast abscess. Okay, the mother could have a breast abscess, and you need to know, okay, so the staph from the mother got to the baby through the breast abscess. Okay, so you could probably be given a gram stain. So you should be able to recognize gram-positive cocci clusters in a gram stain. Okay, now enterotoxin, an important virulence factor. What does it cause? Food poisoning, less than or 4 to 6 hours, isn't it? So you have a case of food poisoning. What are the commonly implicated food? Mayonnaise, milk, dairy products, yes. So somebody eats this kind of food and starts vomiting, and it's within 4 to 6 hours, you're thinking of food poisoning. Of course, what is the nature of the toxin? It's a preformed toxin, it is heat stable, and it's also a super antigen. Okay, this is also a super antigen. Okay, now protein A, you know, what's a property of protein A? Binds, yes, the immunoglobulin molecule by the Fc portion. Okay, so coagulase is an important virulence factor, walling action. So this pretty much summarizes the important virulence factor of staphylococcus, and you can figure out how to associate it with certain characteristics. We could just play around with one syndrome, classical syndrome, and ask you about another virulence factor. Okay, this pretty much summarizes this. Okay, so let me give you the good news. We are not going to test you on antibiotics in this mini. Okay, I know you are so confused. So we are not going to test you on any antibiotics, except there are 2 situations. I'll tell you about it when we come to that, okay? 2 situations, that is regarding mycoplasma and chlamydia. You have to know the association of certain antibiotics. I'll tell you about that when we come to it, okay? So this is about Staphylococcus aureus. I pretty much covered everything that you need to know about Staph aureus, okay? I can email you these, what I've written here, these notes. Then, Staph epidermidis. Now, when you're thinking of Staph epidermidis, the same factors, you see, it's a gram-positive cocci, so I'm not going to go into that. So here, what's the important virulence factor of Staph epidermidis? Virulence factor. Okay, what infections are associated with Staph epidermidis? Device-related prosthetic devices. So obviously, any examiner would like to know what is the association of Staph epidermidis with prosthetic devices. Why? Because it produces dextrin slime, isn't it? Because this bacteria produces slime or dextrin, therefore it can adhere to prosthetic devices, slime, glycocalyx, or biofilms. So this is a concept that is often tested. Okay, Then staph epidermidis is coagulase negative and novobiocin sensitive. Sorry, yes, novobiocin sensitive. Okay. So what are the other infections that can be? Okay, staph epidermidis, not really. So saprophyticus. Yes, it is novobiocin resistant and UTI, urinary tract infection. So these are the three: Staph aureus, epidermidis, and saprophyticus. You know how to differentiate now between them, and you know what are the most common infections caused by these three. Yes, you have a question. Viridins, yes. You see, these are just different names that are used for the polysaccharide that is produced by these bacteria. Dextrin, glycocalyx, slime, they all mean one and the same. Okay, it's just various names. You should be familiar with these different names. Now, in case of Pseudomonas, alginate is also a kind of a polysaccharide, but it is produced only by those cystic fibrosis strains. Okay. Okay, so now we move on to the Streptococcus. Oh God, what's this? So Streptococcus, we look at group A Streptococcus first. So that is strep, yes, gram-positive cocci, chains, and catalase negative, and of course it is beta hemolytic on blood agar. Okay. Now, what are the important virulence factor of group A Streptococcus? M protein, good. Lipotic, what does it use M protein for? Attachment, uses it for attachment. Its disease association, we'll talk about it a little. Okay, then other virulence factor? Hyaluronidase. Then anything else? Yes, streptolysin, and then erythrogenic toxin. Isn't it? Erythrogenic toxin. So let us focus on these three. The M protein is used by the bacteria to adhere. It's also closely associated with lipoteichoic acid. Okay, lipoteichoic acid. So what is which disease? What's the association of M protein with a disease? How does the bacteria use M protein? Okay, before that, resistance phagocytosis. Does it resist phagocytosis? Yes. This also, it uses it to resist phagocytosis, isn't it? Okay. So the disease association of M protein is with rheumatic fever and glomerular nephritis. These are both post-streptococcal infections. And what is the immunological basis? Rheumatic disease is what type of hypersensitivity? Type 2. And glomerular nephritis? Type 3. Good. Okay. So, rheumatic fever, glomerular nephritis, post-streptococcal infection, mostly associated with M protein. So, you could be asked, these tested any of these aspects of M protein and its ability to resist phagocytosis. Hyaluronidase. So, if we are testing you on hyaluronidase, what kind of infections? Hyaluronidase plays an important role in spreading. So maybe a skin infection, necrotizing fasciitis. You could be given a case of necrotizing fasciitis, and then probably asked which of these virulence factor is helping the bacteria to spread, because it's a skin and soft tissue infection. Now, erythrogenic toxin. So what's the most common infection caused by group A Streptococcus? What's the most common? Pharyngitis. Pharyngitis, group A Streptococcus. Which age group? Children, isn't it? Yes, children. So now, how will you recognize a case of pharyngitis? What would be the most common symptom? throat pain, isn't it? Throat pain, enlarged lymph nodes, patient presents with the child is not refusing to eat, fever. These are common symptoms of pharyngitis. Now, what is the connection of erythrogenic toxin with pharyngitis? What's the erythro? What's the connection? What is that disease where there is manifestation of the toxin along with pharyngitis? It's the scarlet fever, red, scarlet fever, strawberry tongue, sandpaper rash. Okay? So, if they give you a case of pharyngitis with strawberry tongue and sandpaper rash, obviously the question would be, what is the toxin that is responsible for this? And that is erythrogenic toxin. Anything else that you know about erythrogenic toxin? It's also a super antigen, and it is also coded by a phage. It's a phage coded super antigen, the erythrogenic toxin. So we could ask you, what controls the production of this toxin? Which is the other phage coded toxin? Which is the other phage coded toxin? Diphtheria. Diphtheria, isn't it? Diphtheria. Cholera toxin is also phage coded, but that's not that commonly tested. Diphtheria and this erythrogenic toxin are both coded by a phage. It's also a super antigen. So the toxic shock syndrome toxin is a super antigen. The enterotoxin of staph is a super antigen. This one is a super antigen. Okay? So, group A streptococcus, the most commonly tested clinical disease is a pharyngitis, scarlet fever, and then of course the what's the other one? Post-streptococcal diseases, rheumatic fever, as well as glomerulonephritis. Okay, and then these virulence factors. Is there anything else about group A streptococcus that is important? Yes? Anything else? Okay, ASO test. What's ASO test? What is the ASO test? What exactly is anti-streptolysin O? What is it? It's nothing but an antibody. It's an antibody against streptolysin O. So obviously, streptolysin O is produced during a streptococcal infection. Antibody remains, isn't it? Antibody stays. So that's why the antibody is used in diagnosing rheumatic heart disease. Because during the phase of rheumatic heart disease, you don't see the bacteria. Bacteria is gone. Okay? So you look for the antibodies, anti-streptolysin O. Okay? So that pretty much covers group A streptococcus, beta hemolysis on blood agar, catalase negative, and bacitracin sensitive. Bitch slapping. Okay? Remember. Okay? So, yes. Bacitracin sensitive. Okay? So, yeah. Thank you. So, yeah. So, we are now, both Dr. Pai and myself, we are trying to learn your lingo so that, you know. Yes. Then, the next streptococcus, that is pneumococcus, Streptococcus pneumoniae. Now, pneumo is often described as a diplococci. Okay, so remember that. And what is its most important virulence factor? The capsule. So, everything associated with this capsule. It's a diplococci with a capsule. What are the other characteristics? What type of hemolysis? Alpha hemolysis, optochin, sensitive, and bile soluble. Okay? So, optochin sensitive, bile soluble, alpha hemolytic, gram positive, diplococci, and it is catalase, of course, all streptococci are catalase negative. Okay? So, these features, just these 4 or 5 features, just keep that. That is associated with pneumococcus. So, we could give you a case of meningitis, somebody what type of people are prone to pneumococcal meningitis? Okay, any other? Somebody who has either middle ear infection or cranial trauma, because the pneumococcus from the nasopharynx can just reach the brain. Okay, so pneumococcal meningitis, unlike meningococcal meningitis, you don't catch it from someone else. You don't catch it from someone. Pneumococcal meningitis is always mostly endogenous. So when there is cranial trauma or severe middle ear infection, it can sometimes give rise to the meningitis. Okay, so the capsule is a very important virulence factor made up of polysaccharides, the vaccine of pneumococci. You have the 23 valent, then you have the 7 or 9, that doesn't matter. But for children, what type of a vaccine is it? It's a conjugate vaccine, okay, for children. Conjugate vaccine. So, know how to recognize streptococcus from a gram stain. It's a gram-positive diplococci. And the common infections caused are pneumonia and meningitis, and these are the characteristics of pneumococcus. Very easy to associate these characteristics and the symptoms of pneumococcus. Any other virulence factor of pneumococcus? Good, IgA protease. I was about to write that, yes. So IgA protease, how does IgA protease help this bacteria? At the mucosal surface, it helps to split IgA. Okay, so at the mucosal surface, it helps to split IgA. So remember, the meningitis is very common, and pneumonia. Okay, these are the two. Then of course you have otitis media. These are the 3 infections mainly caused by pneumococcus. So we could give you any one of these infections and ask you what is the virulence factor, or ask you what is the characteristic of the microbe. How do you recognize alpha hemolysis? Green, yes, green. Okay. Now, the other streptococcus is group B streptococcus, which is also called A. galactiae, yes. So, what is the most common infection? Neonatal, yes, neonatal meningitis or sepsis or pneumonia. All these are together in a neonate, okay. So how does the newborn get neonatal meningitis with the group B streptococcus? From the mother's genital tract. So mothers will carry this bacteria. So all the characteristics like group A streptococcus, except that it is bacitracin resistant, okay. This is bacitracin resistant, otherwise all the other features are the same. Beta hemolysis and catalase negative and neonatal meningitis. This is the most common infection seen in neonatal meningitis. So that's about group B streptococcus. Nothing, very pretty straightforward, nothing complicated about this bacteria. Then Enterococcus. So when you're thinking of Enterococcus, where is this bacteria residing? Yeah, gut. That's why the name. So Enterococcus resides in the gut. Therefore, it should have some property that is different from the other streptococcus. And what is that? And 6.5% sodium chloride. It is because, this is why the bacteria can live in the gut. You see, Enterococcus can live, or it can multiply in 40% bile and 6.5% sodium chloride, because the gut conditions, other streptococcus normally cannot survive in this. Obviously, what are the infections caused by Enterococcus? Gut associated, isn't it? So UTI in catheterized patients, okay. And you also have another streptococcus that's very closely related to this, that is Streptococcus bovis. Again from the gut, in colon cancer, Any other infection caused by enterococcus? Endocarditis. And in whom? Endocarditis, what is the predisposing factors for enterococcal endocarditis? Colonoscopy. Colonoscopy can push both these, bovis and endocarditis, into the bloodstream. See, that is the connection. Because these bacteria are present in the gut, colonoscopy can introduce these two bacteria into the bloodstream, and then think of somebody who has, defective heart valves. These bacteria from the blood will go and latch on to damaged valves. So, subacute bacterial endocarditis. Staph epidermidis. What kind of endocarditis? What was the one single word that you should remember with prosthetic devices, isn't it? So, it causes endocarditis in prosthetic valves. Prosthetic valve endocarditis. Epidermidis, prosthetic valve endocarditis. Enterococcus streptococcus bovis can cause subacute bacterial endocarditis, generally following cystoscopy or colonoscopy, okay, because of its association with, so colonoscopy, okay. So, another feature of enterococcus is its intrinsic resistance to antibiotic, okay. It is resistant to cephalosporin, intrinsically resistant to antibiotics. This is quite a hardy bacteria, okay. Now, Streptococcus viridans. Viridans, why is it called viridans? Because green, alpha hemolysis. This is optochin resistant, okay, and it is not bile soluble. What's the infection caused by Streptococcus viridans? Again, endocarditis, yes. Endocarditis, where does it live? In the oral cavity. So, again, following dental extraction or any other kind of manipulations in the oral cavity, viridans can cause endocarditis. Endocarditis, normally patients will complain of weakness, malaise, low-grade fever, and then you can sometimes hear a murmur, so a new murmur. So these are some of the clues for endocarditis, and so you now have quite a few bacteria that can cause endocarditis. You have epidermidis with prosthetic valves, you have enterococcus with damaged heart valves, you have viridans with damaged heart valves and dental extraction, okay. So that's a connection that you need to make, okay. What are the predisposing conditions and why these bacteria cause endocarditis? That is, and they'll give you probably a clue. What's the virulence factor of viridans? Dextrin, yes. Dextrin, the sticky substance. Because viridans produces dextrin or sticky substance, it can stick to teeth. The group of bacteria, Streptococcus viridans, Streptococcus mitis, salivarius, they are all generally called viridan streptococcus. They can adhere to teeth because of the dextrin, and they are associated with dental caries. Okay. So we have covered the streptococci, the most common infections. So now you have a pretty good idea about which virulence factors. You don't have to remember all the virulence factors. The most important virulence factor, they are obviously associated with certain infections. Okay. So from these gram-positive rods. Okay. Now in gram-positive rods, let's just look at Clostridia. So you have Clostridium perfringens. Just one infection. What is that? The gas gangrene. So gas gangrene, you see gas, crepitus, and it's a necrotic infection. What is the most important virulence factor? The alpha toxin. And what does this toxin do? Lyses all cells. That's it. How do you get this infection? Crush injury. So you would probably given a case of somebody who has suffered a crush injury and then he develops pain, crepitus, purplish lesions in the skin and tissue. Obviously, you'll think of Clostridium perfringens, and the virulence factor is the alpha toxin. What's the other feature of this bacteria? Spore. Yes, the spore. How do you destroy spores? Good. Autoclave, 121 degrees Celsius. Yes. So that's about Clostridium perfringens. That's all what you need to focus on in Clostridium perfringens. Other infections are not that high yield. Now next is the other Clostridia, tetanus. Okay. Now what is the most important virulence factor of tetanus? The toxin. And what's the action of the toxin? Inhibits, yes, GABA. And so it gives rise to spastic paralysis. Okay. So you know that tetanus is also through spore. It's a spore. It's an anaerobic bacteria. And what is normally asked is, how do you prevent tetanus? So say for example you have a 15-year-old boy who is suffered a road traffic accident, and he says, I don't remember when was the last time I took the tetanus toxoid. Maybe when I was in, I don't remember. He's 15 years old. So what do you think? But he says, I know as a kid my childhood immunization schedule is fine. What would you advise? Yes, give him a booster. Okay, so generally the question will focus on these. They'll give you a situation where you need to figure out whether this person needs a booster or whether this person needs the complete immunization schedule or whether the person doesn't need any immunization at all. Okay, so if you have a similar case and he says, look, I just took the tetanus booster 6 months back. Nothing, just clean the wound, leave it. There's no need, because it will be counterproductive. If you go and give another booster, just, person has taken the booster, you give him antibiotics for his wound infection, for his infection, and send him off. Okay, so in tetanus, this is what you need to know. Okay, when to give a booster, when to give an immunoglobulin. So if this person, yes, if he has not taken, immunoglobulin is given to someone who has never taken a vaccination. He doesn't know. And again, suppose say for example he is 20 years old, okay, and or 60 years old, like that old, we discussed a case of an old person who doesn't even remember whenever he took that is too long ago, you can't take the risk. A 15-year-old boy, his childhood booster, last booster would have been probably 10 years back. Just give him a booster dose, okay. And there is a point to your question. It also depends on how bad and how terribly contaminated the wound is. If there is a very high risk of tetanus, then you could think of giving an immunoglobulin. Okay, a very dirty wound. Yeah, otherwise a booster dose is fine. Okay, so tetanus, this is what you need to focus on. Then of course botulinum. Oh. Pardon me? Yes. 10 years. 10 years is good enough. And most of the people, after 10 years, it wanes. So that's the time. Okay. So botulinum, again, spore and toxin. Okay, so spore in, what are the two types of botulinum? Infant, yes, yeah, infant botulinum. It's the ingestion of the spores, colonization of the gut with the bacteria, and in adult, it is ingestion of the toxin. Okay, so this could be in the food. So, an infant botulism case, usually they say the child's formula was sweetened with honey, because you cannot sterilize honey, you cannot autoclave honey. The spores usually contaminate the honey, and the infant could probably eat the honey. The spores colonizes the gut. So the action of the toxin is basically it inhibits acetylcholine. Okay. So what are the symptoms usually? Yeah, in a baby, flaccid paralysis. In an adult, what would be generally the presenting symptoms? Dry mouth, blurry vision, double vision, and then paralysis that usually starts of the face, neck, and it descending paralysis. So generally the adults will complain. That's the common presenting. So you could be given a case of someone who complains of dry mouth, constipation. Okay, in a baby, refusal to feed, staring ahead, flaccid or floppy baby syndrome. Okay, so botulinum, basically to differentiate between the adult and infant botulism, action of the toxin, and then of course the test. So in case of adult botulism, what are the tests? You can detect the toxin, because it's a toxin, isn't it? Toxin in the food, toxin in the blood. And in case of infant botulism, yes, stool. So you can, detect the toxin or the bacteria in the stool. Okay. Okay. So that's about botulinum. Then you have the difficile, C. diff. So in whom will you see C. diff? What is the most predisposing? Yeah, that's a disease. But in whom? What would be the classical patient profile? Somebody who has been on antibiotics for a long time, post-operative, elderly, mostly elderly, post-operative, who has been taking antibiotics. Which antibiotic? Yes, clindamycin or cephalosporin or a broad spectrum antibiotic. Okay, so this is generally the most important predisposing factor, and then the patient has, yes, watery, bloody. It usually starts off as a diarrhea, watery diarrhea, which then turns bloody, usually blood, and then pseudo membrane. Okay. Now, what are the toxins? Two types of toxin, A and B. One is a cytotoxin, and the other is a enterotoxin. Okay. So causes destruction, cytoskeleton, rearrangement, and the other causes the outpouring of fluids. So the diarrhea and the damage to the cell, the pseudomembrane, is a combination. This is because this causes the diarrhea, and this causes mainly the dead cells. Okay. So C. diff, how do you treat C. diff? Okay, I'm not, yeah, yep. Okay, sorry. A is the enterotoxin and B is the I'm sorry, yes. Pardon me? No, I mean, it will be, option would be either enterotoxin A, exotoxin A or exotoxin B, and you definitely need to know the cytoskeleton, which one is enterotoxin, and just, yes. Yeah, this should be, this is A. This is A and this is B. I'm sorry. Pardon me? The enterotoxin causes the diarrhea. That is clear. I mean, entero causes the diarrhea, and the cytoskeletal rearrangement that causes the death of the cells, and that is responsible for the pseudomembrane. Isn't it? The pseudomembrane is an aggregation of dead cells. Pardon me? Pardon me? Is it both? Cytotoxin is B. B is the cytotoxin. Cytoskeletal rearrangement, and it causes death of the cells. That is what is mainly responsible for the pseudomembrane. Okay. A is the enterotoxin. Okay. So so how can you prevent, or suppose you have a case of Clostridium C. diff? What are the measures that are normally taken? What is the infective form? Infective form? C. diff. How do you get C. diff? How does a patient get C. diff? That is the clindamycin predisposes. Why does he get C. diff? From where? Yes, all the flora gets wiped off and then the spores colonize the gut. Spores. So the measures are to reduce the spore contact. And so what are some of the common measures that is taken? Whatever can be autoclaved. Anything that comes in contact with the patient should be, you should reduce the contact with the spores. So autoclaving all the inanimate objects, bed pans mostly. Okay, and also reduce contact with the patients because you could be bringing in spores from the environment. Okay. Then C. diphtheria, CD. So what would be the classical presentation of diphtheria? Classical presentation. How is the patient going to present? It's a case of pharyngitis, very ill child, fever, and then of course you have the pseudo membrane. Okay, what is the most important virulence factor? What's the most important virulence factor? The toxin. What's the action of the toxin? Yes, elongation factor 2. It inhibits elongation factor 2. Yes. So which other toxin resembles this toxin? The Pseudomonas. Yes, the Pseudomonas toxin. Okay. So C. diphtheria, the classical, anybody can recognize classical diphtheria, know the mechanism of action of the toxin and know what causes the pseudomembrane. So it is cytotoxic, it is neurotoxic, and what's the third? Cardiotoxic. Yes, cardiotoxic. Okay, and what is the morphology of CD? It is pleomorphic and matchstick with metachromatic granules, Chinese letter pattern. Yes. Okay, so you know the morphology of C. diphtheria, isn't it? Okay, so that's about C. diphtheria. Then actinomycetes and nocardia. Filamentous bacteria. How do you differentiate actinomycetes? Okay, what are the infections caused by actinomycetes? Yes, usually, yes, it's draining sinuses, yellow granules. So those are all good buzzwords for actinomycetes. Yellow granules, then lumpy jaw. Lumpy jaw. So when you crush these granules, when you crush them, what will you see? Crush and gram stain them. What will you see? Those are these granules. You're crushing them and staining them. What will you see? You will see filamentous bacteria, isn't it? These granules are nothing but clumps of bacteria. So when you crush the granules, these yellow granules in the pus are nothing but clumped bacteria. So when you crush them, you will see the filamentous bacteria. And this what is actinomyces? Is it an anaerobe? Yes, it's an anaerobe. And what is the origin? What's the endogenous, isn't it? They are present on the mucous membrane. Nocardia. Yeah, aerobe. Yes, the most important is it is partially acid fast. Modified acid fast, partially acid fast. What's the drug of choice for treating nocardia? Sulfa. And actinomycetes was penicillin. Okay, so you get nocardia infection from the environment. It's an aerobe, partially acid fast, and sulfa drug for the treatment. And who gets nocardial infection? Chemo, yes, immunocompromised, usually chemotherapy patient. And then what are the two sites? Lung and brain. So they normally present with abscess or nodules, nodular lesions in the lung and brain. So classically, a patient, nocardia patient with lung and brain lesions, and you can see the modified acid fast. That's the most important, partially acid fast or modified acid fast stain of nocardia. Okay, then okay, so gram-negative rods. Gram-negative rods. What's the time? We have 5 minutes. Yes. So yeah. Oh yeah, I forgot about bacillus. Yes, thank you for reminding me. So bacillus, again, it's a spore bearer. Okay, so bacillus anthracis, gram-positive rod, spore. Spores does not cause bulging. Then what's the typical appearance of the bacteria? Chains, boxcar. Then on blood agar, what kind of colonies on blood agar? Medusa head. Okay, white colonies, rough Medusa head colonies. So these are the characteristic. What is the virulence factor? What's the virulence factor? Capsule, which is made up of glutamate, glutamic acid capsule, isn't it? So what would be the classical case of anthrax? Mainly affects the lungs initially. So if the patient can present with fever, malaise, respiratory symptoms, and bloody sputum. So lungs are primarily affected. You will see blood in the sputum, and you will also see mediastinal widening. Yes, okay. And then, so you could give, sometimes they may not give you mediastinal widening. If they don't give you mediastinal widening, they will give you some characteristic of the microbe. Gram-positive rod. There is no other gram-positive rod that causes lung infection. Okay, so anthrax can cause pneumonia, anthrax can cause meningitis. So when they give you a case of meningitis or pneumonia with gram-positive rods with a blood agar picture, you don't have to look any further. Okay, they may not be mediastinal widening. So you have to know, if they give you mediastinal widening, then it's very obvious. So if they don't give you mediastinal widening, they will give you some other characteristic of the microbe, which you should be able to figure out. Okay. So that is anthrax, and then the gram-negative rods. So if you're looking at the gram-negative rods, like, let us look at E. coli first. So E. coli, gram-negative, what else? Pink, no indole. Pink, lactose fermenting on which agar? McConkey, okay? Okay, so McConkey's agar, lactose fermenting, pink colonies, gram-negative rod. Then it can, it causes UTI. So what is the virulence factor for UTI? Why? Pili. Okay, so if they are asking you about UTI, they will definitely ask you about the pili. The common fimbriae, type 1 pili, type 1 or T pili. Okay, so that is one infection caused by E. coli. Then ETEC. What does it cause? Traveler's diarrhea. So it could be a case of somebody who traveled to either South America or Southeast Asia and then suffers from watery diarrhea. What is the virulence factor? What is the virulence factor? What is the virulence factor of ETEC? Huh? What is the diarrhea, watery diarrhea due to? Yes, the virulence factor is because of the toxin, isn't it? Which causes ADP ribosylation and elevation of cyclic AMP, exactly similar to the cholera toxin. ETEC toxin is a prototype of cholera toxin. Causes elevation of cyclic AMP, gram-negative rod, lactose fermenter, produces pink colonies of McConkey. That is all what you need to know about ETEC. Then, that's all. Then, yes, EHEC. Okay? Now, how do you get EHEC? Yes, hamburger. So, improperly cooked meat, ground meat, beef especially, and also from fruit juices, apple cider especially. Why? Because apples, they drop down to the ground and they can get contaminated with cattle feces. That's why apple cider, spinach, some of the, veggies and leaves that we eat raw. Okay. Then, what is the symptom? EHEC? Yes, hemorrhagic. So, bloody diarrhea, no inflammatory cells. What else? What is the other H? What is this? What is the complication? The hemolytic uremic syndrome. So, you see EHEC, hemorrhage, hemolytic uremic syndrome because of thrombocytopenia and the anemia, destruction of RBCs, the toxin that is produced. What's a toxin? What's the action? This resembles which toxin? The Shiga-like toxin, 60S ribosome. So, because of the inhibition of protein synthesis, that is partly responsible for destruction of the RBCs. Hemolytic uremic syndrome is a serious complication of EHEC. Children, renal failure, it can lead to renal failure. So there is thrombocytopenia. So you could get a case. So when you see a case of hemorrhagic diarrhea with thrombocytopenia, immediately think of EHEC. That is what distinguishes this bloody diarrhea from other diarrheal diseases. And because it's very important, it's common in the US, it's frequently tested. Okay? So the toxin is the 60S. You see bloody diarrhea, you see the hemolytic uremic syndrome, and the foods that are associated, and it's mostly seen in children and elderly. Okay? They are most likely to suffer from the complication. Okay? So I think you have a class, isn't it? Next. So do you want me to continue afterwards? Yes. Okay. So I'll be back at what time? 4:30? 4:30. Okay. Yeah. Okay. Thank you. Thank you. Yes. Pardon me?
How would you differentiate between Shigella and EHEC? Doesn't Shigella cause
No, Shigella is a non-lactose fermenter.
Oh, yeah.
Okay,
So
this is sorbitol. This is sorbitol. Okay, and shigellosis causes mucus.
Dr. Bharati, do
Yes.
you eat chicken?
Pardon me?
Do you eat chicken?
I do. Thank you.